So I get to be the lucky one to follow Dr. Osorio during COVID, which is obviously very glamorous. And I get to follow up with fatigue, sleep deprivation, burnout, and depression. And why do we care about this? Really for three reasons. The most important one is that we care about you. We really do care about your well-being. We want you to be healthy, not only now, but throughout your career. All of these things affect doctors throughout their careers, and doctors are uniquely bad at self-care and taking care of themselves. They're good about taking care of others, but not focusing on themselves. We also care about this because it affects your patient care, right? So, there's more medical errors and stuff when all these things are occurring. And then finally, and this is being a little bit selfish, you're all going to be asked about this in the annual ACGME survey in the spring. And I hope that you're all going to remember that I gave you this talk, because they're going to ask if anyone talked to you about these topics. If you think back to your orientation when you had to do those like 50 modules that you had to do, one of those was on fatigue and sleep deprivation, and one was also on burnout and depression too. So you've gotten this several different ways. But you can see this is on our recent survey. This is where we have to be compliant with, or the national average. People were saying that we hadn't talked to them about this. So this is why you're getting this talk. And I'm going to remind this to you several times throughout the year that we had these discussions, but really take this to heart because it's really about your health. So let's talk about a little bit about excessive daytime sleepiness, right? There's 4 things that go into it. There's getting insufficient sleep, whether that's you're on call or you're not recovering from sleep well. There's obviously the disruption in your circadian rhythms by working on nights or doing rotating shifts. There's fragmented sleep by being woken up with your pager, your phone calls, if you have kids, your partner, your cats, whatever. And then if you have a primary sleep disorder. When are the high risks times of fatigue? So there's many of them, right? And you can see them up there. It's working through the night. It's the early hours of a day shift. It's when you're doing your first shift of night call after you come back from a break. It's when you're changing service. So you can see all that. And here's a bunch of myths about sleep. And I think you've probably heard all of these. I only need 5 hours of sleep, so none of this applies to me. No matter what you think, that's not true for anybody. There is no one that only requires 5 hours of sleep, not even Donald Trump, even though he says that he does. Individuals vary in their tolerance, but you really can't judge accurately whether you've gotten enough sleep or you're lost. Everyone needs about 8 hours. It goes anywhere from 7 to 9. And getting less than 8 hours, you start accruing a sleep debt that you're going to have to pay off at some time or another. You will adapt to less sleep. This is also not true. This is a genetically determined thing and cannot be changed. You don't adapt to getting less sleep. You just become a worse performer. And even though you may be able to improve a little bit with just kind of improved focus, you're really not going to improve your cognition. So this is why this is concerning. I know when I'm too tired to perform and I'm not functioning optimally. This is actually not true as well. People underestimate their level of sleepiness and overestimate their alertness. The sleepier you are, the less accurate your perception of the impairment is. And you can actually fall asleep briefly without knowing it. We've probably all experienced this, right? Where you've kind of zoned out for a minute, either in a lecture, when your friend's talking to you, or sometimes when you're driving. Hopefully not when you're driving, and you don't realize where you've been for a few seconds. A nap will only make me more tired. I get used to night shifts anyway. Also not true. Some sleep is better than no sleep. So napping actually can be very helpful. You just want to do strategic napping. I just need a cup of coffee or an energy drink. Obviously we all live and die by caffeine, and it can be useful. The effects help within 15 to 30 minutes, and it can last anywhere from 3 to 7 hours. The problem with caffeine, it oftentimes disrupts your subsequent sleep. You become tolerant to it. For those of us that are older, it can have a diuretic effect, even for younger people. And actually, it doesn't really help your cognition. It makes you more alert, but it doesn't make you think any better. Signs of excessive sleep, I think you all know these. Repeated yawning, nodding off, micro sleeps, increased tolerance for risk-taking, lack of engagement, inattention to detail, decreased cognitive function, irritability, increased errors, loss of appetite, increased susceptibility to illness. Chronic sleep deprivation can manifest as impaired memory consolidation. So you're actually not able to remember things as easily. So for those of you that are going to be taking boards and doing steps and all that stuff, this can affect you as well. There's been lots of studies on medical residents about this over the last 20 years. And sleep-deprived residents are generally grossly inaccurate judgments of their impairment level, just like everybody else. These are the last two things are, I think, some of the most important things that I think are really amazing. So being awake for 17 hours impairs your performance to the same level as having a 0.05 blood alcohol content level. And then being awake for 20 hours, just 3 more hours, impairs your performance the same level as having 0.1 blood alcohol content. So I can remember back when I was a resident, we used to do oftentimes every third night where we're on for 24 hours. So I was running around half the time with this, you know, the same kind of level of having a 0.1 blood alcohol, taking care of patients. You know, we're very fortunate in our program that we don't have 24-hour call, and this is one of the reasons why that was changed. Luckily, we don't drive in New York, but sleep deprivation is the second leading cause of cars and truck accidents. And it's actually been shown in residents that work the night shift, they had a markedly increased chance of having some sort of car accident when they were driving home. So this may affect all of you when you go off into residency, or not residencies, but fellowships around the country. It's also been shown there's a greater risk of having needle sticks, et cetera, in residents. And then obviously there's decreased satisfaction and decreased motivation to learn when you're sleep deprived. And that's not just for residents, that's for anyone that's doing any kind of education. These are the things you want to look out for: falling asleep in conferences, feeling restless and irritable with staff, colleagues, family, and friends, having to check your work repeatedly, having difficulty focusing on the care of your patients, feeling like you just don't care. So what can you do about it? So there are some things that you can do. I'm a big, I love naps. I've always loved naps. Naps can be very helpful, right? The key thing to think about with naps, though, is you want to be careful of doing more than 30 minutes, because if you do more than 30 minutes, you have to remember that that 15 minutes wake up time is there because you're going to have what's called sleep inertia. So you're not really going to be as sharp in those 15 minutes when you wake up. That doesn't really happen when you're sleeping for less than 30 minutes. You want to avoid caffeine 3 hours before you go to bed. You want to avoid exercise 2 to 3 hours before you go to bed. Hopefully none of you are doing nicotine. And you want to optimize where you're sleeping, right? So you want to try, if you have a family or kids, keep them out of the room, decrease the noise, make it a cool, dark room, etc. You want to try to take advantage of your circadian rhythm. So the best times to nap are from 2 to 5 a.m. and from 2 to 5 p.m. If not, though, nap when you can, right? So any sleep is better than no sleep. You want to try to get 7 to 9 hours. Before going into night calls and stuff, you want to make sure you're not starting off sleep deprived, because that's going to make it even worse. You want to try to have a good pre-sleep routine, which includes not working on your devices for at least a half an hour to an hour before you go to bed, right? We're all guilty of checking our emails and checking our texts and all that stuff before we go to bed. That's the worst thing you can possibly do. Avoid going to bed hungry, but you also don't want to overdo it. And again, regular exercise can help you, but you want to try not doing it 3 hours before going to bed. You obviously want to try to make the kind of environment as best you can. And then for night flow, you really want to, make sure you're getting really good sleep beforehand, napping before work to make you more alert over the nights. You may want to try to divide your sleep into 2 4-hour periods. So when you go home, sleeping for 4 hours, getting up, doing some stuff throughout the day, then trying to sleep a little bit more before you have to get up and come in overnight. Light exposure can help you, but not in the morning. So the worst thing you can do is leave the hospital and go home and get lots of light exposure before you want to try to go to sleep. So it's really good to try and wear a hat, wear sunglasses or something like that. But you want to get kind of a lot of light exposure as you can when you're trying to be alert. That's not a problem in the hospital where we have all those horrible fluorescent lights everywhere. All right, anybody have any questions about sleep deprivation and fatigue? Does everyone know where the call rooms are in our hospitals? Who can tell me where the call rooms are in our hospitals if you need to take a nap? Bruno, do you know?
I know there's one next to MICU at West. So there's a room where the fellows generally stay, and there's a door just beside this room that's a call room.
Okay, and how about if you're not working in the MICU? Whereas if you're just on the regular floors?
Yeah, for the other ones, I have no idea.
Does anybody know?
Anyone that has done floors at West and has sat in the 9A area?
Yeah, there's a room, a call room at 9A, just where
Perfect.
the residents sit on the A and B, A side, yeah.
There is, that has 2 beds in
Yeah.
it where you can go down and sleep. I will also point out, there's also our new lactation room right next to it. For those of you that may be having children, right? We have 4 residents that just had babies. We built a new lactation suite there. So there's a 2-chair lactation suite next to it. And if anyone needs the code, we'll give it to you. Who can tell me where the call room is up at Morningside?
It's up at the 7th floor, I believe, near the MICU.
Okay, so that's the one if you're in the unit. Where's the one for people who are on floors? And some of you may never been there because it's a little bit scary.
I don't think anyone has used it in a while.
Okay, so we actually have a call room up on the 9th floor where all the other call rooms are. We have one just for medicine that has 2 bunk beds in it. And so we will make sure you guys know where that is. And I can't remember, is there a code on the door?
It's actually in the contact sheet that we put in every single documentation room. So if you look in the bottom, you'll see the culprit and the directions to the call room.
So there are places where you could go take short little naps. We prefer you don't do anything else there in the call rooms, right? This is not Grey's Anatomy or anything like that. So just use it for short little sleeps and resting. All right, so now we're gonna go on to depression, burnout, and substance use and your overall well-being. You're all gonna get asked about this again on the survey, but this is also something that has impacted our residency. I mean, I'm not sure if you guys know, but a year before I started here, one of our residents did commit suicide, unfortunately. And then a year once I was here, one of our new attendings who was a fellow at Sinai and a previous resident of ours also committed suicide. So this is something that affects every program across the country. There were just 2 suicides at Lincoln Hospital earlier this year. So this is something, you know, I really want you guys to know about, not only for your own personal self, but also, you know, your guys are the community for all the other residents. So I want you to look out for all your other residents as well. And if you pick up anything that you're a little bit concerned about, obviously you can, you know, approach the person yourself and try to help them, but you should also bring it to our attention as well. Both the chiefs and any of the program leadership. And that's oftentimes how we find out if someone is struggling. One of the other residents comes to us. You know, I will say doctors are like ducks. You know, everyone looks like they're doing well on the surface, but their feet underneath are going like crazy. You know, we're all very good about hiding the things that we're going through, but it's usually the closest people around you that are going to pick that up. And we really want to look out for each other. All right, so let's talk about this. So obviously burnout affects physicians at all levels, and it's related to kind of you know, poor work-life balance. It can affect trainees, senior practitioners. It's not unique to physicians, obviously. Nurses, other clinicians can have it as well, as can other people in any other field. And obviously this was a huge problem pre-COVID, and it's even more of a problem post-COVID because of how much everyone has been working. What does burnout look like? You know, it's emotional exhaustion. You're just kind of frustrated, tired of going to work, hard to deal with others. You just want people out of your space. It's detachment cynicism. It leads to less empathy, etc. It leads to low personal achievement. You know, you find work unrewarding, or you're just going through the motions. It can lead to personalization. You don't really feel like yourself. You know, it's been studied a lot in residents, physicians, and you know, med students. So the interesting thing is med students actually start out with less burnout when they're going into med school, and then that quickly changes, right? The pattern reverses in med school, and by the time we become residents, physicians, our burnout rate is actually higher than the rest of the population. You know, but it's highly prevalent. You know, in one study in residents, it showed the burnout rate was anywhere from 41 to 90%. It rises quickly in the first few months of residency. You know, we all kind of thought that the ACGME work hours were going to make all this go away, but it didn't really make it go away. So clearly it's not just the hours that we work. And in some ways, the hours, kind of compressing the work we had to do in less hours made things worse. But this also leads to medical errors and lower quality of care. And that's one of the other reasons we care about this, right? So what goes into clinician well-being? Obviously, there's three different parts of your environment, right? There's the work environment and the work that you do. It's the learning environment because you're here to learn, etc. And then there's personal and the professional factors. You know, a lot of you have families. So like when I go home, I don't have anything else to do except take care of my two cats. I have no kids. I have no partner. I can just lay on the couch and just do whatever I want. But many of you have other responsibilities, right? For those of you who have kids, I don't know how you do it. You have a second job when you go home. And I say that to all of my partners with children. But even for some of you that have partners, you know, your partner wants to engage with you when you get home, right? And you may just be tired and you just want to go in the bedroom and lie down. So you want to think about all those other pressures you have. And then we have the other pressures that are going on with what's happening in the rest of our families, right? You know, our families are far flung around the US and around the world. Many of them are in places where COVID is a lot worse than it is here, and we're worried about them. So there's lots of other things that goes on, obviously, besides just what happens to us at work. And then we'll talk about all the other things that make us unhappy with the work that we're doing. But here's some of the causes of MD burnout. You know, and I really think a lot of this goes by age, right? The things that are going to make a 60-year-old physician feel burnt out are different than what's going to make a physician in their 20s feel burnout, and then the people in between, right? You've probably all seen the cranky old attendings railing against the system and the insurance companies and their lack of autonomy, et cetera. You know, people that trained in a different time don't necessarily feel that. But also people feel like they're losing control, the government's kind of taking over medicine, et cetera. For some people, it's just the different respect that physicians get now than maybe when they thought they were going into medicine. So lots of different reasons for burnout. Who's the most burnout? So this I find interesting, right? Because we have a whole bunch of different people on this call. You can see here's people doing general internal medicine, and on the bottom is what percent felt burnt out. And then along the side, or the y-axis, is how satisfied were you with your work? And obviously the red is the worst place to be because you're not satisfied with your work and you're feeling burnt out. And here's where general internal medicine is. For some of you going into the subspecialties, you're over here. You know, you would think that dermatologists would be completely happy, right? Because they're making all this money and, you know, they shouldn't be burned out, but they're actually in the orange area. I was kind of surprised to see that. Here's our rehab colleagues too. Here's our ER colleagues. You know, the happiest people in medicine, preventive and occupational medicine. I guess that's not entirely surprising, right? Because they're not seeing sick patients, that kind of stuff. But I think this was interesting. All right, consequences of physician stress and burnout. Obviously, there's professional and personal, and they're both equally important, right? So from the professional side, you know, there's poor judgment in care, hostility towards patient, medical errors, adverse events, et cetera. But on the personal side, these are even more important, right? Because these are things that are going to affect you for the rest of your life. It's depression, anxiety, sleep disturbances, broken relationships. You know, the divorce rate amongst physicians is much higher than the general population. Alcohol and drug addiction, early retirement, and then obviously suicide, which we want to avoid the most. Here's just something showing the impacts of burnout on patient safety though. This study was looking at, and this is using the Maslach scale for burnout, you know, for reporting of major medical errors on, whoops. Where did that go? There we go. On each floor is where the primary work record for patient safety was either excellent to failing. The reporting of major errors was worse when the burnout scores were higher than when the burnout scores were less high, right? So, you know, it can have an impact on the errors that are going on. Everyone knows about safety net, right? I'm just gonna make a plug for safety net. Who can tell me what safety net is?
It's a mechanism to anonymously report something going wrong, something you feel unsafe.
Fantastic. And it's really not just things that are unsafe. It can be anything. It can be mistreatment. It can be, near misses, etc. It can be anonymous, but you can also get an answer back if you'd like to get an answer back. But the other thing, it's a way that there will be some sort of investigation. If something is put into safety net, someone is going to look into it. And so that's where I think the most important part of safety net is, because oftentimes, the residents will report something, they feel like it goes into this void and nothing ever happens. We will get an answer back through safety net. And there is a way that you can anonymously get an answer back if you don't want people to know who you were, so you can hear what happened with that. So I would encourage all of you to put things into safety net. The residents are the least frequent people to put things into safety net. 95% of things in safety net are put in by nurses. Well, I shouldn't say the residents are the least, the attendings are the least. So the nurses do about 95%, the residents do about maybe 4%, and the attendings do about 1% of the things in safety net. All right. So why is burnout increasing in medicine? Lots of different reasons, right? So, it can be that there's more demand on seeing patients, et cetera. The EHR has made a lot of people unhappy. It had a lot of benefits, but it's a lot of clicks that we have to do and lots more documentation that we have to do. Rising negative views of doctors. I mean, I think that's one thing that's frustrated people. It's not seen as like the noble profession that it used to be. And the longer hours that we all have to work. And also the compression of hours. So, duty hours for residents were great, but they didn't take any of your work away. They just had you do it in a shorter amount of time, which isn't necessarily a good thing. You can see all those same reasons, right? Financial strain, et cetera. For those of you that, have huge debt, that can be really hard. When I came out of school, I only had about $100,000 in debt, but I only paid it off when I was 51, which was only 2 years ago. So I've been paying that debt for more than 25 years. Some of the students coming out now have $450,000 in debt. That's a huge crushing debt to start your life with, and that's got to be something that gets fixed in this country. The concern about being sued, et cetera, there's lots of different reasons why, kind of burnout has increased. And obviously during COVID, everything has just gotten a lot worse, right? Because there's more demands on our time. I think a lot of doctors now are getting frustrated because people aren't really, taking on the benefits of vaccination. So maybe not so much in New York, but I was just talking to Dr. Farris down, who some of you may not know her, but she used to be our hospitalist director at West, and now she's at the Dell Medical School in Austin, Texas, where they're having a huge amount of COVID cases and the vaccination rates are very low, and they have that stupid governor that isn't forcing anyone to get the vaccine, right? That's really frustrating for doctors when we have the benefits for science and people just aren't taking up the benefits of science. So this is just a recent survey about for doctors of why were internists burnt out. And you can see it ranges anywhere from too many bureaucratic tasks all the way down to having either a difficult employer or difficult colleagues and staff. So it's not the same for everybody. But here's one of the issues about why physicians are the least likely to get support, right? So one, they feel like it's going to get them into trouble or it's going to follow them. So nobody wants to kind of get help, right? That's not unique to physicians, right? People in the military don't want to get help because they're macho, whatever, etc. But, doctors, we're all kind of type A and we all think we should be able to, be the best and not want to show any kind of weakness. The imposter syndrome too is where you're just trying to hide. You don't really feel like you should be where you're at, right? So there's lots of different reasons why doctors don't report, but we should report. We talked about this. So there's kind of 3 stages of, kind of what concerns us about burnout. The first one is just daily burnout. You just come in, by the end of the day, you're exhausted. You're feeling underappreciated. You're tense, you're angry when you're working with patients and stuff. And, I'm sure you've all seen this, and I'll just point out the attendings. I want to point out where the residents, where sometimes it almost seems like the attending feels like they're being bothered by the patients, right? And frustrated by, the never-ending problems, et cetera. So you can also have physical symptoms. You can just feel like, there's too much work for you to do and you just can't keep up that intensity, et cetera. And then we go to the second level, which is distress. right? Where you're just starting to lose your idealism, you're getting a little bit cynical, your general loss of interest, you're not able to study as much as you want to, right? You feel like you have no control over your life. It's always you have Dr. Andrilli telling me where I have to be. You want to rail at Dr. Andrilli in the program, right? That's very, disgusting. You're also losing kind of your interest in, kind of the rest of your career. So it's hard to focus on getting to that next level. You do things outside of work and they're just not feeling refreshing or enjoyable. So then you start isolating yourself. And then we end up getting to major depression, right? Which happens, right? And these are the things I think you all know and are aware of these things, but these are the ones we want to be most alert for, right? Because we can intervene here. So suicide risk, it's different for males and females. So for depression, for the lifetime risk in males is about 10 to 20% for physicians. It's a little bit higher than for non-MDs, but the suicide risk is about the same as non-physicians. It's very different for females though. For the lifetime risk of depression in female physicians, it's 20 to 50%, a lot higher in the non-physician world. And the suicide risk though is 3 times higher than non-MD women. And I'll point out again, the 2 suicides in our program were both females. That is not unique though. The 2 suicides at Lincoln Hospital were both males, but there does seem to be a difference between males and females. And no one obviously is sure about why this is exactly. Probably has also, partially to do that females oftentimes have to be, in charge of everything that happens at the home. I have lots of friends who are couples, and no matter how, useful the man says he is, the wife will tell you he's actually not that useful. And so I'm not maligning men, but I think that's one of the things that puts more stress on women. And that's also kind of like the roles that people see women should be in. Depression, the way it can affect residents is you're much more likely to make errors. And that's not just for residents, that's also for attendings as well, right? You're going to make more errors if you're not, there 100% on your job. It is estimated that up to 400 physicians commit suicide a year in the United States, which is a huge number, 400 people. So what do we want to do about this? So be a friend to yourself and to others, right? Look out for burnout in people. Look out for people. See if they seem like they're exhausted. Don't seem like they're taking joy in their work, or they've kind of not taking joy in anything else, right? Look at yourself. Are you starting to feel worthless? You're not finding any meaning in what you're doing? Be cognizant of that, because there's things that you can do. And really, I want to stress this again and again. We have to look out for each other. And that includes your seniors, your peers, your attendings, everybody. If someone just doesn't seem to be acting the way you think, you should bring it to somebody's attention. Don't do that. Substance abuse disorders, obviously extremely common, right? Common in the non-physician population, but also common in the physician population, about the same. Benzo and opiate use, this may be changing a little bit now, is probably a little bit more common in the physician population. Does anyone know why that is? Why do we think that's more common in the physician population?
Access.
Why?
Access.
Access, right? Access. So I don't know if anyone, so there was just an anesthesia physician admitted to the non-teaching service at West for benzo abuse who had easy access. I will tell you, when I was at St. Vincent's and we had a practice on 18th Street, we had a GI physician who used to see patients in the office, and for months the staff was telling us that something wasn't right with him because he would disappear for an hour, and he usually worked in the evening, so most of the doctors wouldn't be there. And then one time, one of the staff, he wasn't coming out to see a patient, and the staff walked into his office and he was there with a needle in his arm, injecting himself with Demerol, right? So there's many things that happen with physicians. Obviously, it's a little bit higher in anesthesiology. Anesthesiologists have the highest rates of substance abuse for all doctors, again, due to access. What are symptoms of impairment in the workplace? I mean, I think you guys all kind of know these, frequent absent tardiness, inappropriate orders, heavy drinking, obviously at social functions, conflicts with your coworkers, rounding at odd hours. There's always the attending that seems to come in and write their notes at 11 o'clock at night when no one else is here, a decline in your work performance, etc. Obviously, dependence, you guys all know this as well. Someone coming with bloodshot, watery eyes, dilated pupils, sleeping all the time, poor physical condition or hygiene, etc. And you can read the rest of them. So there's two things I want you to know about this. So one, for the AMA, there's some policies related to physician health. So one is that's the duty to practice medicine unimpaired, right? We're here to be taking good care of our patients, and that's a personal responsibility thing, right? Which means we shouldn't be using anything, obviously, when we're working, but we also shouldn't be coming into work when we may not have gotten the adequate rest we've gotten. If we went to a happy hour last night, and we're going to be letting you know about a happy hour we're having for all of you next week. But obviously, we don't want you staying out late, drinking and then coming in somewhat impaired. And that's your own personal responsibility to make sure that you aren't doing that, which means should you have a problem, you should be telling the chiefs, I'm not right to work today, and then we can deal with the consequences of that later. But there's also an ethical obligation to report your impaired colleagues, right? And nobody wants to do this, obviously. We don't want to get anyone else in trouble. But ethically, if you know someone is treating patients impaired, you really need to bring that to someone else's attention. And then obviously you have an own duty to preserve your own personal health and performance. For residents in the common program requirements, it's the same thing, right? Residents and faculty must demonstrate an understanding their own personal role and assurance of their fitness to work, and including recognizing impairment in themselves, in their peers, and other members of the healthcare team, and bringing that to someone's notice. Not because you want to get someone in trouble, but you want to get someone help. And that's, the one thing. There are many ways for doctors to get help that allow you to continue to practice and not have anything on your personal record, right? So I've, personally supervised people who have been impaired physicians, and, they usually get assigned a mentor. So one of my previous residents from St. Vincent's had a problem with alcohol use, and I actually, was his state appointed mentor for the next 5 years, and had to meet with him regularly to make sure he was on the right path. And again, none of this will be punitive. We want you to be healthy. We will get you the help that you need. So you shouldn't look at it as we're gonna, get you into trouble. Obviously, we want to do this so you avoid getting yourself into trouble, right? The worst thing you can do is, end up hurting a patient or hurting another person because you do something because you're impaired that leads to more and more problems. All right, so what do we have to actually help you, right? So one, there's the Wellness Hub that you can all sign up for if you'd like to. What you do is you go to the Sinai Central, and there's this little thing on the left, and I'm going to send all this to you that says Wellness. And then what you'll do is you sign up for it, and then you get this little app on your phone that is the Wellness app from Sinai. And I'm just going to show it to you. I don't know if you can see that, right? So that's the Wellness app from Sinai. And it will give you lots of daily tips about wellness. It will send you like a daily survey if you want to answer it to kind of judge where you're at wellness. It's got a whole bunch of like daily yoga routines if you want to do that. There's a whole bunch of things in there that you can, play around with. And it's completely confidential. So no one's going to be tracking you. It's not going to be telling us whether, you're impaired or anything like that. It's just something that the Office of Stress Resilience and Personal Growth has set up for all members of the Sinai team. So if you want to sign up for that's available for you. The other thing that's available for you is the peer-to-peer support. This is if you have any kind of bad encounters at work, you have a bad patient outcome, oftentimes when there's a death, etc. We will reach out to you from the program when we hear about it and offer you peer support if you feel like you want to talk to someone, whether that's another physician or another member of the care team. So each of the sites has their own peer support number that you can call, and then someone will reach out to you and give you confidential peer support. So I will send that out to you as well. And then finally, we have the Student Training Mental Health Program. And this is not only a 24/7 support and crisis hotline that you can call at any time if you need help, but you can also get counseling. If you just want some counseling, career coaching, any of that, that's also supplied as well. I want to stress this is all confidential. So you do this on your own. I never hear about it. The program never hears about it. It's covered by your insurance. Usually if you want to see someone, they'll set you up with someone not at either one of our institutions. You know, it oftentimes will be someone on the east side or a private person in the neighborhood if you feel like you want to talk to someone. So I would encourage all of you to take advantage of these services that are available for you. And we've had many people that have taken advantage of these services, and they've had really good benefits, both, you know, residents and attendings in the program. So these are the things that are available for you, and I would hope you would take advantage of them. Anyone have any questions about any of that? Concerns? You want to talk about anything else while you have the PD sitting here in front of you?
This is your chance.
I mean, obviously you can talk to me any other time too, but. So I did mention that we're hopefully going to be having a happy hour for you. We're just setting up the details. Hopefully that will be next week. It'll be on a beautiful terrace about 2 blocks away from here, so it's outside. It's where we had a mini graduation thing at the end of last year. It's a really nice space. We can have up to 100 people there, so we're hoping to get everyone there who's not on call. Unfortunately, if you're on call, I can't help that. We gotta let you be on call, but hopefully that'll be for a lot of other people. No questions, no comments?
I don't see anything.
Everyone's going to remember to answer that we talked to you about some of this stuff in the spring, right? Because I'm going to beat it into you every quarterly for the next time. But also because we want you to avail yourself of these services. Really, we don't want any more issues with anyone not doing well here in our program. And if you are having an issue, we're going to help you through it, because that's why we're here, right? To get you through anything. All right, guys.
Thank you, Dr.
Then you get 15 extra minutes before your next
Unless
issue.
you've been burnout and soon 15.
Exactly.
So you can start.
Take a nap on the couch. Nadeem, you look like you already might be there. I'm just kidding. You were awake.
Sorry, but yeah, I'll take you up on that quick nap.
All right, guys. Thank you.
Stay on.